So just briefly about diabetes insipidus, it's an abnormally increased production of a hypotonic urine, which can lead to hypernatremia and elevated serum osmolality. There's 4 mechanisms that can cause diabetes insipidus. These are hypothalamic, and that's from an inability to secrete and or synthesize vasopressin. There's also nephrogenic, which is an inappropriate renal response to vasopressin. It can also be seen in pregnancy transiently due to accelerated metabolism of vasopressin, and then primary polydipsia due to just excessive water intake. And 50 to 60% of patients will have some transient diabetes insipidus within 24 hours of pituitary surgery. And there's a 0.5 to 15% risk of permanent DI after pituitary surgery. Nemmergut et al. Evaluated 881 patients who underwent transsphenoidal surgery and found the following risk factors for DI after pituitary microsurgery. Microadenoma, but this was transient only, and then craniopharyngioma, Rathke's cleft cyst, and intraoperative CSF leak. If there's a complete stalk section, then they can have this triphasic diabetes insipidus. And this consists of the first phase, which is diabetes insipidus within 24 hours post-op up until day 6 postoperatively. And this is thought to be due to axon shock and inability for these action potentials to propagate from the cell body to the axon terminals in the posterior pituitary. The second phase is antidiuresis, and that occurs generally from day 7 to day 12. And this is thought to be due to unregulated release of vasopressin from posterior pituitary axonal stores as they degenerate. And this is happens due to the lack of a regulation of vasopressin release, and then with excessive administration of fluids, and that can lead to hyponatremia as in other cases of SIADH. And then this has sometimes actually been seen without the first phase of DI. And then in the third phase, around day 13, there can be a recurrence of the diabetes insipidus, and this is after all of the vasopressin has been released from the posterior pituitary, so the stores are gone. And this can be either permanent or partial or clinically unapparent. And in our patient, it's yet to be determined how she's going to turn out. Right now, she seems to be managing okay, so we'll see how she does in 6 weeks.
Are you giving her anything at night?
No, the plan was that if she started having more symptoms, that she would call, and then we would consider a dose of DDAVP at night.
You said 1 to 5 times a night.
Yeah.
1 would be tolerable. 5 times a night.
Well, it's variable. So she says at her baseline, even before the surgery, she was waking up once a night, which Dr. Heaney thought was unusual to begin with. So it's unclear, but she said one night it was 3 times, one night it was 5 times, one night it was once. So no, this is post-op. Pre-op, it was about once a night. Oh. And she's definitely drinking more water than she did before the surgery. But she doesn't feel... Right. So...
So you did restart her thyroxine.
She never went off of it. Yeah, she's been on it the whole time. Yes, Dr. Rinherley.
When you saw her in clinic, let's say on day 13, was she still complaining about headaches?
No, actually, she was on Percocet when she was discharged because she was having headaches, but not pre-op. This was post-op headache that first required Vicodin, then was up to Percocet. And on the post-op day 6, when we saw her, she was still taking Percocet. And then we had really advised her to try to wean down to just plain Tylenol, which is what she was taking. So she was still having headaches, but they weren't nearly as severe, and they were only requiring regular Tylenol. Yes.
This may be an embarrassing, naive question to ask, but is it possible that she never showed a hypernatremia for DI?
Although we treated her right away.
Yeah, I guess that's where I'm going to show my ignorance. Could it be that she was taking more fluids in than she was urinating out, and her DI was very marginal?
Right, she was keeping up with the loss. Exactly.
Or am I missing something more basic?
Well, there is something more basic here, which only recently have I begun to think about the importance of thirst in the pathophysiology of the posterior pituitary. A student asked me a year ago in one of the comments after my lecture on this, why don't you make a table that that differentiates hypersecretion of vasopressin and hyposecretion of vasopressin. And I thought, oh, that's kind of crazy. And I used to think that, people would say, why don't you differentiate insulin shock from diabetic coma? Well, those are such different things that never made sense to me. But I did make such a table. And the interesting thing is this, thirst is very important in pathology. So when you have too little vasopressin, you secrete urine, and you should get hypernatremic. Why don't you? Because we're very good at turning on thirst. We're very good at turning on thirst. So they present with polyuria, polydipsia, and a normal sodium. Mm-hmm. That's the situation. Now, when you have too much vasopressin, and you aren't excreting very much urine, we are not good at turning off thirst. So you present, so that you do get hyponatremia, you present with hyponatremia. If we were as good as a rat at shutting off thirst, you would present with because you can give a rat DDAVP, you can pump it until the cows come home, and they will not get hyponatremic. And the reason is they absolutely stop drinking. So they present with a very low urine output and a normal sodium, just sort of the opposite of GI. But humans don't do that because we do not shut off thirst.